Welcome to our webinar on how to make a new denture on an old hater bar. For many years, the hater bar has been the most popular bar attachment in the world. Tens of thousands of overdentures retained by hater bars, often with distal extension ERA attachments, exist in patients' mouths. When the overdenture needs to be remade, what do? How do you make the impression? What parts represent the bar in the model? And what if the bar is worn? How do you successfully make a new denture without getting in trouble? These are the types of questions I'm going to answer in this recording. Now, it's important to know what a hater bar is in order to figure out how it will be handled and what kind of problems you can run into. So we're going to take a look at what the hater bar consists of, how they are actually made, and this will lead us into the idea of what some of the problems are. I should introduce myself. I'm Jim Ellison. I'm head of the technical department for Stern Gold, and if you do have any questions at the end of this recording, you can always email me at james.ellison@sterngold.com. Well, these are the components of a hater bar starter kit. It consists of two 50mm long plastic bars. There's a round part and a flat skirt. Now, the round part is approximately 1.8 millimeters in diameter. Therefore, these same techniques would be effective when used on any round bar that measures about 1.8 millimeters in diameter. And I will show you a couple of other bars which fit into this description. The yellow clips are normally the ones that are used on the bar, and they're retained in the denture, oftentimes in a metal housing. These long-legged green fabricating riders on the right are, well, they're often misunderstood. This has the same type of round clip like the yellow, but it has these long legs. They're meant to be buried into the stone in a processing model, but some people mistakenly try to put them onto the bar. That doesn't work. Even if you cut the legs short, you try to put them on the bar, the internal dimension of these fabricating riders is too small, and the legs splay out to the side, and they make too big a place within the denture when you process to them. So don't put them on the bar. I'll show you how they're used correctly in a few minutes. This is the seating tool. It's basically a handle. You put a clip on this end and pop them into the place in the denture. Well, this is a very typical design. We see three sections of hater bar, and you'll notice a distal ERA attachments. These happen to be the ERA RV. Now, it's a very good idea to have a distal extension attachment. And years ago, before the ERA was developed in 1985, I would sometimes put another cantilevered section of hater bar out there. Well, the problem with that design is we're going to, in this case, put, let's say, one clip here. Therefore, the rotational plane for this denture, if it could rotate, would be right through that section of bar. But when we have a distal extension rigid attachment, like another section of hater bar, it stops any hinging. Therefore, that design would be much more implant supported. Much more force is going to those implants. If we would like to share the load more with the ridge, so we'd have some going to the implants and some going to the ridge, we should use a resilient attachment here, and that's what the ERA is. It moves up and down. So as the clip is rotating slightly around the bar, the denture moves up and down, and we add some of the occlusal load to the entire ridge area. That's why it's always important to extend our denture base all the way back into the retromolar pad. The other reason why it's good to have a distal extension is most of the occlusal load when we're crushing food is going to be in this second premolar, first molar region. The closer we are with our attachment to that region, the more stable the denture is. So it'll be more comfortable for the patient. The problem I find with this denture is that these implants are too close. Now, one way to avoid that situation is to use the denture as our guide. With every partial denture, with every overdenture, we always begin with the denture. And the denture dictates the position of the implants, the types of attachments we can use, where we put those attachments. These are the way they should be made. Unfortunately, particularly when we're making a new denture on an old case, we don't always have that luxury. So I'll talk about how this is originally made and how we can avoid some of those problems. But I'll also cover, if you do find yourself in trouble, then how we handle that. So what would be a better position for those implants is this. We've got some space here. We have enough room to put at least one clip on there, maybe two, and we could use these, although there's plenty of retention with just one Hayter clip and two distal ERAs. In fact, it's actually too much retention for some people, so you have to be careful if this is an older person with some limitations to their manual dexterity. You would do better probably with 4 freestanding abutments if there was, let's say, some arthritis or other dexterity issues. In any case, this denture was designed first, and then the denture was used to figure out where to put the implants. In other words, a surgical stent or guide would have been used, which was derived from the denture. So we either have to have a good denture, and if it's an existing denture, we'd have to at least reline it, and then we would check the occlusion, see if everything appears as close to ideal as we can get it, and then we use that to place our implants, and then we use it to place our attachments, in this case the bar and the ERAs. Now I wanted to show you this metal, see the little metal edge there. This clip is housed in the Hayter bar metal housing, and we'll see that a little later. That's a choice. You don't have to use it, but it is quite common today to use that, because when you go to change a clip, let's say this is a couple of years old and the clip is worn a bit, you would take a scalpel blade and slit it the long way, collapse the sides inward, remove the whole clip, put a new one on the end of the seating tool, and pop it into place. That's going to be more positive if you've got a metal housing there than if you just had acrylic. Although with composites today, with heat processed acrylic, I've done literally hundreds of them with the clip just held in the acrylic. In fact, you'll notice that the ERAs are here only in acrylic, and yet today probably 95% of people use the metal housings, which we call metal jackets, for the ERA. So they would be, and we'll see the metal jackets on the ERA a little later. The other thing to point out here is normally in a maxillary overdenture, I try to avoid this horseshoe shape. I think it would be, well, full palatal coverage would be the best because we'd have the greatest amount of support from the tissue. However, it's not all that comfortable for the patient. So in order to open up the center, what I would prefer is to use a narrow posterior palatal strap. In other words, make a metal frame here. Have the center open, have a little broader anterior palatal strap, and then a narrow posterior palatal strap to keep the tails of the denture from flexing, because then, in the case of the upper, we would tend to lose suction and it might drop down. So better, and it would be much more stable to have that. So that's my preferred design. Now in this case, this was done at in the post-grad PROS program at Ohio State University, and this patient had a very high vault in their mouth. So there's, you can't really see it in his denture, but there's lots and lots of acrylic here and a lot of stability, so they didn't need to have the frame here. But in a normal denture, what I'm concerned about is that it might fracture. Right through the center here would be the weakest point, and particularly in someone who has a fairly strong bite. So I'd be worried that that would happen from time to time, and therefore the metal frame would also work to stave off that problem. The way we adjust retention with a hater bar is, well, you notice here there were 3 places made in which we can snap a clip, yet there are only 2 here. In fact, we could have 1 or 2 or 3. So that's one way to vary the retention. The other way is with the color of the clip. The yellow is the traditional clip, but there is a white clip that is less retentive than the yellow. So if I was dealing on, let's say, an older patient with manual dexterity issues, I might put one white clip in the middle so they get used to it. And then we can always slip that out and put in another one or change to the yellow. We're also talking about old hater bars here, and sometimes we find the bars are worn. So there is a red hater bar clip that is a little tighter than the yellow, and you may need to use that for older cases. Now the reason why the bar could be a little smaller than the normal 1.8 millimeters in diameter for the round part would be if, well, as you see, this is cast. So it starts as a plastic pattern. It must be sprued, invested, cast, sandblasted, and polished. So in that process, depending on the skill of the technician, could be undersized a little bit. The other thing is if someone casts the bar out of too soft an alloy, we find that, well, fairly often that somebody would use, say, your average type 3 gold that has a Vickers hardness of, let's say, 130. We say in the instructions for the hater bar that the Vickers hardness needs to be at least 200. And because I'm an old belt suspenders kind of guy, been doing this for 49 years, I'm looking for 300 on the Vickers scale. So I'm going to use, well, if I'm using a Crown and Bridge gold, I'm going to use a type 4 gold, and I'm even going to heat treat it. If I'm using a ceramic alloy, I would use the silver palladiums, or I would use even a non-precious, although it's not my favorite thing to use, and we don't see much non-precious metal. The steels are traditionally not used with implants, but you could have this supported by roots, and someone may have used that. That's fine. They're certainly hard. They will resist wear. But that's when the red clip would come into play. Now, I mentioned there were other round bars, and there's several of them on the market. This happens to be one. This is the C&M round bar, C&M standing for Cendré et Mateau, a Swiss company, and we are their exclusive representatives here in the United States. But there are other companies that have sold similar round bars. As long as it's in that neighborhood, 1.8 millimeters or so, then these tools and techniques would work for any of the older bars. In this case, you notice that there's a spacer here. This is a soft piece of metal that comes with this. If you order one of these gold adjustable riders, you would, if you wish, lay it on the bar, put the gold rider or clip on that, and the wings here would be buried in the acrylic, and that's how they're retained. Now, of course, when we get to about this point, from here down, all of this area needs to be blocked out on both sides of the bar, the labial and the lingual, because otherwise this gets into an undercut situation, and it would never come out of the mouth if you'd even ever get it in. The other thing is the end of these clips, just like the plastic ones, has to be free from the acrylic so they can flex on insertion and removal. But this clip can be adjusted. So if you prefer a gold clip that can be adjusted, there's this type, there's some Acrylic clips. There's a few around that will also fit on this type of bar, this size bar. Now, as I mentioned, important to start with a good denture. So if you had an existing denture, it would be good to do a reline or rebase. So we starting with a good base and we know it fits the tissue. But let's check the occlusion. Let's see, I would recommend a lingualized occlusion, but as long as we're in pretty good shape here, then we could use that as our guide. And in order to be able to do that, to help us to, one, make a new denture, and two, to be sure that we have everything in the right place, a matrix is a great idea. So here we have, using some lab putty or whatever putty type impression material we might have, we can make an occlusal, buccal or incisal labial matrix of this right on the model. And then when we remove the denture, put the matrix back on, we can see where all of the position of the denture teeth. In other words, this is the ideal position for the denture teeth. So this would be good to, we could make a surgical guide from this and we would be able to see the teeth. If we were remaking the bar, then we could see, well, where should I put this ERA attachment? You know, does it need to be an offset, or can I use the regular ERA RV, or do I need the micro because there's not a lot of space here? Should it be a little more to the buccal? Should it be a little more to the lingual? Because I'm working with the outline of that denture tooth in order to help me to place these attachments. The bar, well, we wouldn't put it up here because we'd be inside the denture teeth. We want to put it down here where it's out of the way. So we'll know going, before we go anywhere, exactly what the ideal is and how close we can come to that. So the denture always dictates the entire rest of the procedure. Originally, that hater bar plastic pattern is marked according to its length between the abutments, and we often use an indelible marking pen to mark the approximate shape of the tissue, the ridge. We would then cut off the excess skirt so that it's about the same contour as the tissue. I like to lubricate the model and add some wax to the skirt to extend it down until it touches the tissue, and then I cast it just like that, and we end up with a little bit of a ridge lap design. Then you would round it and highly polish it so that it's either just touching the tissue or slightly off. I know there's different opinions, and I think if I was to take a poll among all dentists, I'd probably hear three opinions of where the skirt of any bar or any extracoronal attachment should be. I think the majority would be light tissue contact. There are some who'd like to see a millimeter off of there, and some that would like to have even 2 millimeters. Unfortunately, we usually don't have the space to put 2 millimeters between our attachments and the tissue. So the reason that I like light tissue contact is a study done many years ago indicated that anytime you have a bar or an extracoronal attachment, if there is space between that attachment and the tissue, in just under 14% of the patients, the tissue will grow up and fill the space. Sometimes it can actually grow up and impede the function of our attachment. So in order to avoid having to do surgery, at least not too often, it's better, not that it'll always fix the problem, but better if we have the attachment lightly touching the tissue. It will tend to hold the tissue in place a little bit better. Well, after this has been cast, of course, and then polished, the original heater bar instructions said to try it in the mouth, which of course you should do if we're making a new bar. Now, it also asked you, well, asked the dentist to put as many of the yellow clips onto the bar as would fit, and then to block out any of the undercuts here, the end of the clip, whoops, right over there. I can be careful on my height, and all the way down to the tissue. Now on the labial, that's not too hard, but on the lingual, it is difficult to do that in the mouth. In fact, you see, let me see if I can mark this very carefully. Right about here is a step. There's a little projection on the clip, steps out a bit, and that's an undercut where the acrylic must hold these into the denture. So you can't block out that far, yet you have to block out the end. So it's a little bit tedious to do that correctly. Much easier to merely pick up the bar. In other words, if the bar, whether we're on implants and we've screwed it in, we know it's passive, we can then pull the bar in an impression where we can now have a solid model on which we can process our denture. So what I suggest is that all of this area where we put the clips on and do the blockout is done in the laboratory, not in the mouth. So you just pick up the bar. Now the problem with that is if there is space between the skirt of the bar and the tissue, the impression material may wrap all the way, in fact it will tend to wrap all the way around the bar. As you remove it from the mouth, you tend to tear that impression material, making the impression useless. Therefore, what is important to do in the mouth is to do this little bit of blockout. So if there's any space here, just block that out with whatever. There are people who use, well, soft, sticky carding wax is sometimes used in the mouth if the space is small, but I find it doesn't stay put very well in the wet environment of the mouth. I like bite registration materials. I like them because, one, they do stay put quite nicely. You can take and put the small cannula on the end of the mixing tip, and you can just, inject it around here underneath. You can then take a wet gloved finger and smooth off any excess. You also, as I mentioned, you want to block out between the ERAs of the tissue as well. If any of that material gets up onto the side here, we just clean that out with an Explorer so it isn't up around the round part of the bar. And then we're able to make our impression. The other nice thing is the bite materials, the bite registration materials, set very quickly. So it's easy to work with them. Ours, by the way, is called Quick Bite Vanilla. You may want to check that out. It's a very nice bite registration material, has a little vanilla odor, so it's comfortable for the patients. Now, traditionally, we would make an impression of this. The problem is, if we make an impression of that bar with nothing on it, let's assume it is an old bar, 25 years old, been in the patient's mouth. Maybe it was over-polished, maybe it was cast out of something a little too soft. The 1.8 round part is not 1.8. It's now, let's say, 1.6 millimeters in diameter. If you make that impression, and then right here is our heater bar processing jig. It's an analog for the bar. This round part of the jig is 1.8. If I try to push it into the impression when that's a little smaller, it won't seat completely. The impression material will not let that section of jig seat all the way. And in fact, that's exactly what happened. There was a technician from Lauterbach Dental Lab, Dave Caruso, called me one time, and he had that experience. The jig was in the wrong place in the model. He made his new denture, took it back to the mouth, fit the model nicely, did not fit the mouth. And he figured out that this was the problem. The bar was too small and that the jig wouldn't seat properly. So he came up with the idea, and then we worked together to create this. This is a hater bar impression coping. It's a metal housing with a yellow clip inside, although if you had an old bar and it's worn, you could substitute for the yellow the red clip, and it would grip a little tighter. The top is a typical impression coping. You place one of these on any of these straight sections here. You could probably put 3 on here, and you see we put the metal jackets for the ERA on each of those attachments, and now those would be pulled in the impression material. So when we then cut our jig to length, so anywhere we have a straight section of bar, we mark and cut the jig and we seat it into the impression. With that hater bar impression coping in there, it guarantees that the jig will be snapped in all the way. It will position it exactly the same way the real bar is in the mouth. So it will make sure of complete seating. For the ERAs, we have a new metal jacket here, and this is also a processing jig. It's like an analog of the ERA. So it's like an ERA ring with a post on it. And those represent that attachment. So we're going to pour the model, and this is our master model. Now, many years ago when I was much younger, I would occasionally process directly on the master model until I realized that usually we destroy the model when we're divesting it from the denture. If we just try to pry the denture off, we'll break the denture. So we break the stone out of the denture. In doing so, I no longer have a master model on which to deliver the case. So if it doesn't fit well in the mouth, we don't have any reference point. We don't have anything to go back to see where the problem is. So I make sure this master model stays. I do not use it for processing. I'm going to deliver this so we know, okay, it fits the model nicely. If it doesn't fit the mouth, we have to look to another area. And the biggest area or mistake that occurs with making impressions on any area where we have any dentulous ridge is tissue displacement. So just take a moment to talk about that impression. Back in the 1950s, Dr. Steiger and Boytel did some tissue displacement studies. They found that tissue in the edentulous areas could be displaced up to 2 millimeters. Now, if we're off 0.5 millimeter, our attachments probably won't seat. In other words, every time the patient smiles or yawns or opens their mouth, it'll pop out. The tissue rebounds and unseats the denture. So that causes, 95% of the problems when a denture does not seat properly in the mouth. It's just the attachments are not in the right place, and therefore we have to ensure that we do not displace the tissue when making the impression. The best way I know to do that is with a custom tray with a light-bodied impression material in there. However, if you wanted to use a stock impression tray, you could use let's say a putty to border mold and do our initial impression of this area. Then we, of course, would remove. We'd remove some of that putty, that heavy-bodied material around the bar, but we should also, and here's the careful part, we should also relieve that heavy-bodied impression material all the way along each saddle. So now when we took our corrective impression, we would add light-bodied material not just around the bar, but all the way along the saddle areas, so we ensure that we have not displaced the tissue. So this master model, therefore, will have a passive impression of the tissue. So whatever we do here, we ensured that the bar was in the right place. Now we've also ensured that the tissue is properly represented. Well, in order to not destroy that duplicate model, that master model, we want to make a duplicate. So in the lab, they would place a yellow clip onto any section of hater bar. In this case, we're only going to use one, and do that block out. And of course, we can just use wax here and whatever to block out any undercuts and just the end of that clip. We don't need to worry about blocking out around the ear or under the ERAs because there's already stone there. And then we're going to use, I would strongly recommend a silicone duplicating material. I've done this with reversible hydrocolloid just to prove that it could be done. It was brand new, and I was, careful with it. But I think it's well worth the investment. The silicone duplicating materials are much stronger, much more tear resistant, and they're even more accurate. So we can fit everything in there very, very nicely, and it will give us a great impression of this. Now, into the place where there was this, this yellow, blocked out, we've blocked out the labial and the lingual of that yellow clip, we're going to substitute. This is where that green fabricating rider comes in. You can see that the legs are pretty parallel. There's a little space between them right there. And that's important. If you didn't block out enough and you put the long-legged green fabricating rider in, it will push the legs together and they'll touch. If that was the case, you'd take it out, you'd trim a little bit, take your Bard Parker, trim a little bit of that impression material and put it back so that the legs can be parallel. Of course, we'd also need to get, for the ERAs here, we'd need to get another metal jacket and another processing jig, put those into each of those recesses in the impression, and pour our processing model or working model. Now we see we have the green fabricating rider, and those legs represent our blockout. We have the metal jackets in the back for the ERA, and we can go ahead and do our denture setup. So we set up our teeth and the pink wax. We then go ahead and process, and we can use whatever method you like. In this case, we use the traditional brass split flask. We have our model here. Of course, the denture teeth would be in the other half of the flask. At this point, the pink wax has been boiled out, and we're ready to put the lubricant on the model and go ahead and process our acrylic. At this point, if you wish to use the hater bar metal housing, you would slide it onto the green fabricating rider from the side so that it looks like this. Now, the reason I suggest from the side rather than pushing it on directly from the occlusal is these are pretty thin, and you could distort them if you push them on from the occlusal. So push them on, slide them on from the side. You'll also notice there's a ERA metal jacket here. Like I said, this is the RV, so the ERA RV metal jacket. This is just the black male, which is, of course, inside the metal jacket on this side. Now, you wouldn't do this. You wouldn't have one black male and one metal jacket in place. However, it shows that you have this option. With the ERA, unlike a lot of other attachments, you can choose. So if you have very limited space, and although the metal jacket is only 0.2 of a millimeter thick on the occlusal and only 0.3 on the side, if that makes a difference, you could put just the black male in place. You would process the denture, and as we're divesting the stone model out of here, breaking it out, we'd come across those long fabricating riders, and we would grab a hold of them with a pair of pliers and pull them out. Now we'd have, in this case, an empty metal housing. We'd put the yellow clip on the end of the seating tool, although if you determined early on in this process that the red would be better because the bar is worn, then you'd put a red on, and you'd snap it into that denture, into the housing. You'll notice that we have the ERA black males here. Best to leave those at this point and try the denture in. Make any occlusal adjustments that you need, and then in order to create the resiliency of the ERAs, so they will move up and down a little bit, we need to core out the black male. There's a special core cutter burr you put in a lab handpiece to do that. Core out the center button 2 or 3 pushes. The whole process is maybe 30 seconds. You core out the center button with the tool, collapse the outer walls in, remove it completely, put a new one on the end of the seating tool, the ERA seating tool, and pop in the new male. Now the final male, the one with the smallest button, about the same size as the black male, is the white. So in a new case, you'd probably use a white. Or if there's been no wear here over the years, you'd use a white. Because we always use with any attachment, we give the patient the least amount of retention that they demand. If we give them too much retention, first of all, it may be difficult for them to insert and remove, and usually the attachments wear out too quickly. So always go with the least amount of retention. Well, let's say this is an older case, and somebody did cast this whole bar structure out of too soft a gold, and even the ERAs are worn a bit. So the white one, you put a white one on while holding it in your fingers, and they just come right out. No retention at all. Okay, then we try an orange one in. We say, okay, now that's one step up. It's got a little larger center button. Then that fits better. We now tug on it, and we've got some reasonable retention. Or you could go, the next step is a blue. And then there's a gray. And there's even a yellow and a red where the center button gets really big. So if you are really in trouble and somebody has, either way over polished these, or has really, it's 30 years old and has had a ton of wear and was too soft, you can go ahead and get up to that red size if you need to. But always try them on with your fingers first. And that's our denture. So we've made a resilient, brand new denture. It will fit nicely because we considered the tissue when making our impression. We blocked out correctly so that the end of those clips on the header bar are free, and everything will work very nicely in this case if you follow those instructions.